morning.
Sir, are you free now, sir?
Yeah. Last night I was stuck. I couldn't talk to you. Yes, please.
Right, sir. Regarding this facial nerve palsy, I asked certain questions, sir.
Yeah.
What is your indication of facial nerve decompression in cholesteatoma?
In cholesteatoma.
In cholesteatoma.
That means the patient presenting with facial palsy.
Facial palsy. And next is in Bell's palsy. And
these are two different. Yeah.
First I will pose the question. Third one is post-traumatic. And in post-traumatic with immediate grade 6 palsy and post-traumatic with bony spicule impinging on horizontal part of the facial nerve or at first genu.
Yes.
And will you always do decompression of labyrinthine part of the facial nerve in every case? And opponents saying that only 1% is needed, facial nerve decompression is needed, so there is no need. In that 1%, we can do cable grafting or sling or gold implant. And the opponent saying that 99% will recover. So absolutely there is no need of facial nerve decompression in any case, in any Bell's palsy or in any post-traumatic or in any facial palsy in cholesteatoma. And
yes.
And how the rule of 21 days has come. And the proponent saying that after 21 days we have to do facial nerve decompression the next day itself. So this is the whole topic, sir. In your free time you can.
Yes. See, number one, the cholesteatoma. Patient presenting with facial palsy having cholesteatoma are the real candidates for surgery. For the reasons for removal of cholesteatoma, at the same time, once you decompress the facial nerve, the chances of recovery are very good. If it is done, the patient presents early and they have dramatic results. This is the real indication for that once you remove the cholesteatoma sac, the nerve automatically gets decompressed because it is already, the canal is eroded and the nerve is compressed. That's why patient presenting with facial palsy. So that is the right indication that should be taken as a priority and should be done. To your point of facial nerve decompression in Bell's palsy, this is a very, very debatable topic, but I tell you, this is one topic where we have gone through the literature, most extensively, and seen in our practice also. Facial nerve palsy, the Bell's palsy, most of the patients do not need decompression. But there are certain group of patients who really need decompression. But that is less than 1%, 1 to 2% sometimes you can say. And like those patients, I do in that segment of patients, for the reasons I tell you, you go to the Gantz publication. We discussed with the top authority, Gantz, G-A-N-T-Z. Gantz publication, that was a landmark publication in laryngoscope. And he had a very good series of patients where he divided into with or without decompression. Now, there is some science behind it. We cannot be dogmatic in our approach. You will see some people, I will never decompress. You will see some people, I will always decompress. We can't be dogmatic. We have to be evidence-based. So, in patients with facial decompression, there are a small segment of patients who need to be carefully followed and if required decompression. Those patients are, to me, patient presenting with a complete facial palsy. Grade 5, 6 facial palsy. Obviously, wherever the patient goes, the treatment is started with a full dose steroid. Some people give antiviral, some people give, vasodilators, whatever. So, if the facial palsy doesn't improve, 7th day, we get the electroneuronography in our hospital. That will give you a real picture of the axon matrix or neuron matrix, that how much neuronal population is affected. If it is a persistent grade 6 palsy, obviously more than 90% you will find damage. or non-functioning. Then again, we just observe, follow the conservative treatment, and in our center, on the start of third week, 15th to 17th day, we again get the electroneuronography and EMG also. That is very important. If on electroneuronography, if first of all clinically, if the same grade palsy persisting, if grade 6 palsy, suppose persisting even on the 17th day, your electroneuronography shows more than 90% degeneration. Now the final decision comes to EMG. If EMG is not silent, still I will not do decompression. If on 17th day the EMG is silent, then I will definitely convince the patient for decompression. These are the patients, this is a very small subset of population who are really, deserving candidates for decompression.
In centers where there is no electroneurography and EMG, what is your recommended protocol?
Then clinical decision is very difficult. Then the decision cannot be appropriate. And this electroneuronography and electromyography are very simple tests. These are not expensive. Everyone can install in their center.
Then you can recommend 21 days rule. After 21 days, do decompression.
Yes. So after 17 days, even if the electroneuronography is more than 90% degeneration, but the EMG activity is still there, I will not recommend. I will still wait.
Okay.
Patient now, palsy has an immense capacity to recover. We have seen patients recovering even after 2 months. But if the electroneuronography is more than 90% degeneration and still EMG activity is there, I will never recommend. Those are the patients still have potential to recover. It needs to be evidence-based, man. It should not be dogmatic.
Okay.
And only those subset of patients where even the EMG is absent on 17th day, I will certainly recommend for decompression for the reason. Now, there are a lot of studies done. The Gens was the one who started this debate and concluded very well. Those patients who had on 17th day more than 90% degeneration on electroneuronography and EMG silent were divided into two groups. One who were observed and one who were decompressed. There is a significant difference in the outcome in patients who were decompressed having EMG silent 17th day. Maybe 15th day or 17th day. So that is a significant benefit you can confer to the patient. Number one. Now coming to the decompression, it's not that the tympanic or mastoid segment decompression is going to give any change in outcome. That is not the site of culprit. Most of the time, the culprit is at the level of geniculate ganglion and the labyrinthine portion.
In Bell's palsy.
Now, it is very difficult to access that region, transmastoid. But I tell you, on CT scan, still, I know it is difficult, but still in small subset of patients, you can even decompress the labyrinthine segment very well, transmastoid, who have very mimetized mastoid. There is a rule wherein if you see the level of the geniculate ganglion below the level of the tegmen, when the mastoid is extensively mimetized, you can access the labyrinthine segment from the mastoid. And in order to do more extensive exposure, you can go anteriorly by the transzygomatic approach and start dissecting from anteriorly, exposing from anteriorly. Because if you try to expose the labyrinthine segment in those mimetized patients from behind, your superior semicircular canal is at stake. You can damage that. So in those situations, if you are going transmastoid, go anteriorly from the transzygomatic. Then your trajectory of drilling or instrumentation is away from the superior canal, and you can go far distal segment of the labyrinthine segment. But this can be possible in less than 10% cases. Best is middle fossa exposure. So we combine transmastoid and middle fossa. And see, there is a fear among surgeons that middle fossa is an intracranial procedure. Yes, but it is very, very safe. It is absolutely extradural. You don't have to go to the intraortary meatus deep down. You just have to elevate dura, see the GSPN, and stay just few millimeters medial to the GSPN. You are still in the labyrinthine segment, and you can decompress. Then we have to be very skilled, because the cochlea and the semicircular canal are very close on both sides. So that labyrinthine segment is actually compressed between the ascending turn of the basal turn of the cochlea and the superior canal.
Yes.
So you have to be very, very, under high magnification with a very small diamond drill, with a low speed diamond drill. So you can actually do it without damaging, without opening the canal or a cochlea. We have done in several cases. Knowing the fact that you can open, you are more conscious, and you can really decompress this segment, and it works very well in those subset of patients. Only those subset of patients.
This all in Bell's palsy.
Huh?
This whole thing is in Bell's palsy.
Bell's palsy.
Okay.
So this amounts to around 1% of cases.
Okay. Then.
So by and large, every Bell's palsy doesn't need any surgical treatment. I told you, patient presenting with grade 6 palsy, not recovering, on beginning of third week with more than 90% damage on electroneurography, no clinical improvement, and EMG silent are the candidates. Then you take a call whether you can go transmastoid or not about the pneumatization. A good CT will tell you whether you can access the labyrinthine segment transmastoid or not. Every patient you cannot, in less than 10% you can. And then simply you can combine with the middle fossa. It's totally extradural and it's very, very rewarding.
Okay. Sir, if there is, in centers where there is no electroneurography and electromyography, then can we take a 21 days rule as a cutoff point?
Yes, Murli, then you may not be correct always. The reason being, if there is EMG activity going on, how will you come to know?
Okay, right.
That now you may find clinically that now not recovering, but the fibrillation potentials are on, and that now has a potential to recover. That you cannot know clinically.
Okay, right.
So then your decision may be a biased one. You may find clinically nerve not recovering, and still that nerve may recover without surgical intervention. So in those patients, in a number of patients, you may do unnecessary surgery.
Okay. The opponents of facial nerve palsy in cholesteatoma, the opponent saying is that the surgeon is removing the total middle ear ossicles, and facial bridge is lowered, and there will be a big cavity problem, and it is difficult to reconstruct that big cavity. So what they are saying is that the facial nerve palsy in cholesteatoma is due to toxins, not because of the pressure. So what they are advocating is treat for another 3 to 4 weeks, the facial nerve recovers, then do inside-out mastoidectomy and soft wall reconstruction. Will you agree with that? This is all recorded, sir. This is all recorded.
Really, Murli, I beg to differ with this issue. Having cholesteatoma in place, the patient who has already presented with facial palsy, and with this stupid idea, you want to wait for 3 to 4 weeks, is detrimental. I will never wait in a cholesteatoma patient who presented with facial palsy.
Okay, right.
You can reinforce your finding very well by getting a good CT scan done. That will exactly tell you which part of the facial nerve is affected, which part of the bony canal is eroded, and then there is no point in waiting for it.
Okay.
Because this is a sort of complication of cholesteatoma, and then you have to really do something to it.
Okay. In post-traumatic cases, what is your indication? I mean, when you
Post-traumatic again, again there is a myth. First of all, there are two kinds of patients post-traumatic. One who present with immediate palsy, one who come with delayed palsy. A majority of the patients come with delayed palsy. And unfortunately, most of these patients, even patients themselves cannot make out whether the palsy was of immediate onset or delayed because of the head injury, they are admitted in the critical care unit, neuro care units, and then the facial palsy is the thing of least concern in those patients. So they really actually don't know when the palsy actually did happen to occur. So for patients, who have presented with delayed palsy, obviously you have to observe. Okay? But those patients who present with immediate palsy, then you have to do something. And first of all, then a good HRCT is essential. Most of the patients have longitudinal fracture. If you see the longitudinal fracture passing through the geniculate ganglion, you have to wait. Still you have to wait. It's not that always your surgical intervention is responsible for recovery. Most of the patients do recover on their own. Actually, what happens after the fracture, the intraneural hematoma takes place. And most of the patients do recover. The scenario you told, that if there is a bony spicule, this is most of the time hypothetical. You'll rarely see after a fracture a bony spicule got separated and went into the facial now. This is most of the time hypothetical. It actually doesn't happen so commonly. So most of such patients require conservative treatment. That's it. Now, in cases of transverse fracture, the patient will have multiple issues. Transverse means across the longitudinal axis of the petrous bone.
Correct.
Then patient will have a lot of issues, vertigo, hearing loss, facial palsy. That is more of a concern than a longitudinal fracture. So, and most of such patients will have a lot of neurosurgical issues and all, and they present late. And most of these patients, if the facial nerve is totally transected, will require some sort of anastomosis and rehabilitation in the future.
Okay. Next is so when you decompress labyrinthine part, labyrinthine part of the facial nerve, that you are saying in all the indicated case of all Bell's palsy, you decompress labyrinthine part.
Only there is a very small subset of patients. The reason being, in those patients, I can give you number of publications, and even we discussed this year in the Madrid. I was in a facial palsy workshop. We discussed in detail. Those are the patients who are most deserving candidates for decompression, but thankfully those are less than 1%.
Okay.
But in those patients, if you do not, they will certainly have consequences. The decompression really helps.
Okay. And this labyrinthine part of the facial nerve is again divided into straight part and curved part. The curved part between the cochlea and basal turn of cochlea and the superior semicircle.
Yeah.
Okay. Just 1 minute, sir.
A lot of doctors have like you said, the opponents. They will have a proposition that you cannot decompress it without damaging cochlea and superior canal. You can. How good you are at the middle fossa approach, how good you are at dissection in that region, and familiar with the complexity of anatomy, you can. I would never say that one cannot do it without damaging these tissues. We have done several times.
So
this was even the concern to us also earlier, because this is such a thin structure, completely pressed between the two bony prominences of ascending cochlea and the canal. It's really difficult, but you can. You may have to blue line the canal with a low speed diamond, but doesn't make any difference. You can still do it, and once the nerve pops out, it is so rewarding.
Okay. All these cases, you will get on-table recovery of facial nerve palsy?
You can't say.
Okay.
See, in any decompression, you cannot say on-table recovery. It depends on how long-standing it is, because whatever Wallerian degeneration has taken place takes time to recover. But that gives the opportunity to recover.
Okay.
And it recovers faster.
And one case scenario, let us don't mention the names. You said in Mumbai or somewhere, for an athlete, you have done decompression of the labyrinthine part of the facial nerve. Just can you describe that clinical scenario?
I decompress what?
You decompress labyrinthine part of the facial nerve in an athlete.
In an athlete?
Athlete.
I decompress. When?
You said sometime back. Okay.
No, that was the recent Morwani sir's workshop in Mumbai. I did one iatrogenic facial palsy. That was post-tympanoplasty, CS1 surgery.
Okay. In iatrogenic, what is your way of doing in iatrogenic?
Yeah. Iatrogenic is, they see now more and more patients coming. Iatrogenic facial palsy, I would say, it is all because of the lack of three-dimensional knowledge of the facial nerve to the surgeon. Number one. And sometimes you are doing, see, most of these patients happen to occur when the surgeon is not oriented about the course of the facial nerve. And you are drilling in the vicinity, not knowing the facial nerve is there, and ultimately end up injuring the facial nerve. And unfortunately, there are a group of patients, the surgeon is even unaware of the fact that he has damaged the facial nerve. That is worse. But whatsoever, once you find post-operatively a facial palsy, obviously you'll, if you are sure that you have not damaged, you have to wait for at least next morning. Even on the next morning, if the facial palsy is there, even if you are sure that you have not damaged, it needs an exploration. Definite exploration as early as possible. And in the scenario that you have damaged, definitely if you have damage, you have seen the damage, definitely you have to take intraoperative call if you are competent enough. If you are not involved, some senior, and do as early as possible, treat that patient, because these patients require definite treatment as early as possible.
That is cable grafting?
Yeah, and no, it depends. It's not always that cable grafting is required. You remember the Morwani sir's workshop? So in this 30th July, we did a very interesting case. The surgeon who was doing a tympanoplasty was actually exploring the mastoid from behind because of the granulations in the middle ear. And you know what happened? In order to locate the antrum, he happened to stay inferior without knowing that where the antrum is. He happened to stay inferior. He damaged the lateral canal, and with his burr point, he went into the vertical course of the facial nerve, just below the genu. Fortunately, he stopped there, finding something abnormal. So that's a very common scenario when the people are doing this mastoid exploration tympanoplasty. What a single message we tell at our center also everywhere: when you are locating the antrum from behind, use your tegmen tympani as your best landmark and stay along the tegmen drilling down. That will make you 100% safe from going below and damaging the facial nerve. Number one. That is the most important landmark. It doesn't mean that you start with your drill anywhere in the mastoid and start drilling. Because in sometimes you may find a sclerotic mastoid, some abnormally pneumatized. There are a variety of situations. So always first superficially locate the tegmen tympani, and then keep widening and drilling down. Go along the tegmen, you'll always be safe from the fascia. Number one. So in that patient, the surgeon unfortunately ended up exposing the facial nerve. Some part of the periosteum of the vertical segment was damaged. So what we did, We exposed the area and we decompressed the facial nerve. It was really edematous. We decompressed proximally and distally until we found the normal nerve. And actually the facial nerve was not transected. So you don't need a grafting or everything in every case. Even a slightest trauma to the nerve sheath with resultant edema and neuronal hematoma can lead to facial palsy.
Okay.
So, depending upon the situation that what kind of damage you have done, you have to take a call.
Okay, sir. Next call, I will call you regarding animation, reanimation procedures.
Okay.
Thank you so much, sir.
Okay.
Thank you.
Thank you.